Hello and welcome to my presentation on AVAPS. My name is Tori Everly and this presentation was created as a final project for the Technology Applications course in the Respiratory Care Master's program. AVAPS stands for Average Volume Assured Ventilation. It is a non-invasive form of mechanical ventilation that adapts each breath to reach a target tidal volume. It is a smart mode that auto-titrates IPAP to reach a target tidal volume. It can change up to 2.5 centimeters of H2O per minute. It also compensates for leaks and adjusts trigger and cycle values to enable optimum patient-ventilator synchrony. AVAPS can be used in the hospital setting or in home care. On the left, you see a home BiPAP that has AVAPS capabilities. On the right, you see a V60, which is used in the hospital setting. Both of these machines are made by Philips Respironics. AVAPS can be used in the hospital setting or in home. Patients that should be considered for AVAPS are any patients who have chronic respiratory failure. This includes COPD patients, neuromuscular patients, and patients with obesity hypoventilation syndrome. In the traditional ST mode of ventilation, an IPAP and EPAP are set. This results in a fixed pressure support and varying tidal volumes. In AVAPS, a range is set for IPAP, resulting in a consistent tidal volume and varying pressure support. In the initial settings, the respiratory rate should be set 2 to 3 beats below the patient's resting rate. Note that this is a backup rate, not a ventilator rate. The tidal volume should be set to 8 milliliter per kilogram of ideal body weight. Your max P should be set at 25. A conversation with the physician may be warranted before going above 25. Min P should be EPAP plus 4. If you look at the picture on the right, on the bottom you can see where the set parameters for AVAPS go. As with any ventilator or non-invasive ventilator, it's important to set your alarms appropriately. Your high inspiratory pressure should be set just above your max pressure to prevent pulmonary damage. Low inspiratory pressure alarm is set to sense patient disconnect. Low minute ventilation and low rate alarms should also be set appropriately. In the picture on the right, you can see an example of alarms that may occur. The patient at disconnect alarm means that the leak is too high and the ventilator thinks that the patient may be disconnected. Low inspiratory pressure means that the pressure that the patient is getting for their IPAP is lower than your low inspiratory pressure alarm. This may also mean that there's a disconnect. High tidal volume alarm may mean that your min P is set too high and they don't actually need that much pressure anymore. As with any ventilator, AVAPS has real results. With AVAPS, there is increased patient comfort, decreased use of sedation, a greater improvement in ventilation, higher patient compliance and success rates, faster recovery of consciousness, and more rapid ABG improvement. A study showed that 16.6% more patients were compliant with AVAPS than ST. A study of 11 hypercapnic COPD patients with a GCS of less than 10 treated with AVAPS was compared to a control group of 11 patients treated with ST by doctors that were unaware of the study. The patients that were placed on AVAPS recovered consciousness much more rapidly than the patients placed on ST, and the ABGs improved earlier. Additional studies have shown that AVAPS turns patients around faster and wakes them up more quickly than ST. example 1, we have a patient who arrives to the ED with a GCS of 10. The patient has a COPD history, and his admitting diagnosis is a COPD exacerbation with hypercapnic encephalopathy. The physician tells the respiratory therapist that his goal is to improve consciousness and ventilatory status as quickly as possible to prevent intubation. With an initial ABG of a pH of 7.2, CO2 68, bicarb 29, and a PaO2 of 54. He says an additional ABG will be drawn in an hour, and if there's no improvement, then the patient will have to be intubated. Since studies have shown that AVAPS turns patients around faster and wakes them up more quickly than ST, AVAPS would be an effective mode in preventing intubation in this patient. In example number 2, we have a patient who has been diagnosed with myasthenia gravis and is hospitalized for a crisis. The patient has been intubated and extubated, still has some weakness and breathing a little bit shallow. So the physician asked the respiratory therapist to recommend what we can do to prevent this patient from being re-intubated. AVAPS is a good fit for neuromuscular patients because it will assist the patient's spontaneous ventilations and ensure they maintain good ventilatory status. Since this mode also has a backup rate, you don't have to worry if the patient's spontaneous breaths fall below the backup rate level. Example number 3 is a patient who has been using non-invasive ventilation with ST. He's been very compliant with his BiPAP, but the hypercapnia is not improving like it should be. When the respiratory therapist reaches the bedside to assess, he or she sees that the tidal volumes have been varying. The nurse is at the bedside and states that the BiPAP has been alarming low tidal volume all day. The tidal volume low alarm is set at 300 and the low minute ventilation alarm is set at 4. So that means that the patient's tidal volume and minute ventilation have been dropping pretty low. Since AVAPS will titrate IPAP while the respiratory therapist is away from the bedside, AVAPS would ensure better ventilation of this patient and an improvement of arterial blood gases. The following resources aided in the development of this presentation. Thank you for viewing my presentation. I hope that it helped you to feel more comfortable with AVAPS and that you will feel ready to initiate this mode on patients and recommend it to physicians when necessary. Please take the associated survey so I can assess the effectiveness of this